welcome back to the deep dive. I have to be honest with you. Looking at the stack of research we have on the desk today, I felt a distinct shift in gravity. Usually we're diving into tech trends or historical mysteries or maybe, the weird world of mycology. Today, we are opening a file that touches, statistically speaking, almost everyone listening.
It does.
Either you've lived it or you love someone who has.
It is the absolute heavy hitter of modern medicine. We are talking about Major Depressive Disorder, or MDD, and I think the gravity you're feeling it's appropriate because this is a topic that has been trivialized for a long time in pop culture.
Right. And I want to set the ground rules immediately, right here at the top, because the source material is very, very specific. We're not talking about the blues.
Yep.
We aren't talking about that funk you get into when it rains for 3 days straight, or the grief, as painful and valid as it is, that comes after a breakup or a job loss.
That distinction is the first wall we have to break down. The sources we're analyzing today: clinical guidelines, pharmacological reviews, neuropathology papers. They treat MDD as a distinct physiological entity.
A biological event.
Exactly. It's not just a mood swing. It is a biological event. It's a systemic failure.
Our mission today is to decode that biology. We're going to trace the path from the microscopic level, what is physically breaking down in the engine of the brain, all the way to the pharmacological jungle.
That's a good way to put it.
And looking at this list of drugs, it really is a jungle. I mean, we have drugs that change your heart rhythm, drugs that require you to stop eating cheese, drugs that might make you sleepy or keep you awake for days.
It is an absolute arsenal. And it's complicated because the old story we've all been told, the chemical imbalance story, is barely scratching the surface. In fact, relying on that old story is why so many people get frustrated with treatment.
That's the hook that really grabbed me in the prep reading. The idea that you're just a quart low on serotonin and need a top up. It turns out that's a massive oversimplification. It's like saying a car won't start just because it's out of gas, when actually the spark plugs are misfiring and the computer creates a glitch in the fuel injection system.
That's a perfect analogy. If it were that simple, just add serotonin. We'd have cured depression 50 years ago with the first antidepressant. The reality involves receptor sensitivity, hormonal regulation, neuroplasticity.
And even the physical structure of the brain.
And even the physical architecture of the brain shrinking or growing.
So, let's pop the hood.
Right.
We need to understand the pathophysiology before we can understand why the drugs work or, why they sometimes don't.
Agreed.
We have to start with the classic theory, though, right?
Yeah.
It's one everyone knows. The biogenic amine hypothesis.
Right. This is the foundation. It's the classic Coke of depression theories. For decades, the prevailing wisdom was that depression is caused by a deficiency in 3 specific neurotransmitters. We call them the big 3.
Let's map them out for the listener, because these names get thrown around a lot, but I want to know what they actually do. You've got serotonin, or 5-HT.
Serotonin is the great regulator.
Yeah.
It regulates mood, sleep, appetite, and even pain perception. When it's low, the world feels bleak, sleep gets fragmented, and everything hurts a little more.
Then there's norepinephrine.
That's your energy. That's your focus, your fight or flight drive. It's the arousal system. When that's low, you get that lethargy, that late paralysis where your limbs feel heavy.
You can't get out of bed.
Can't get out of bed.
And finally, dopamine.
The rock star, the reward signal, pleasure, motivation, the go-get-it chemical. The hypothesis was straightforward. You don't have enough of these floating around in the synaptic clefts, the gaps between your neurons, so the signal isn't getting through.
The brain goes quiet.
The brain goes quiet, you feel depressed.
It makes sense on paper, it's clean. But here's the glitch in the matrix that the research points out, and this is where the detective story begins. If it's just a lack of fuel, and you take an antidepressant that boosts those levels within hours, why don't you feel better by dinner time?
That is the million-dollar question. We know, pharmacologically, that antidepressants raise the levels of serotonin or norepinephrine almost immediately.
Right away.
Like within hours of the first dose. But the therapeutic effect, the remission of symptoms, the lifting of the fog, takes weeks. Usually 2 to 4 weeks, sometimes longer.
That lag time.
That lag time tells us the problem isn't just the fuel, it's the engine.
This leads us to the postsynaptic changes theory, which I found fascinating. It shifts the blame from the chemical to the receiver.
Think of it like this. If you are in a pitch-black room for a week, your eyes dilate. They become incredibly sensitive, trying to catch every single photon of light. In a depressed brain, Because the levels of neurotransmitters have been low for so long, the receptors on the receiving neurons, specifically the 5-HT1A or norepinephrine receptors, have upregulated.
They've gotten bigger, more sensitive.
Exactly. They are hypersensitive, desperate for a signal. They are wide open.
So when you start the medication and suddenly the lights flip on, you flood the system with serotonin.
The system is blinded. It's overwhelmed. It's actually a shock to the system. The healing process isn't the flood of chemicals. It's the adaptation to that flood. The receptors have to downregulate.
They have to shrink back.
They have to desensitize, shrink back down, and return to a normal state. That physical restructuring of the receptor population takes time, usually that exact 2 to 4 week window we see in clinical practice.
That is such a crucial reframing. You're not waiting for the drug to enter your system. You're waiting for your brain to remodel itself in response to the drug.
Precisely. And that leads into the dysregulation hypothesis. The idea here is that the neurotransmitter levels might fluctuate, but a healthy brain has a thermostat, a homeostatic regulator that keeps things balanced.
Okay.
In MDD, the thermostat is broken. The drugs aren't just adding heat, they are helping recalibrate the thermostat so the body can regulate itself again.
Now, there is one more layer to the biology that I found genuinely unsettling. We're talking about structural changes, actual atrophy. The notes mention BDNF.
This is the most compelling argument for aggressive treatment. We are looking at a protein called brain-derived neurotrophic factor, or BDNF.
I've heard this described as miracle grow for the brain.
That's a fair analogy, a really good one, actually. BDNF helps neurons grow, survive, and maintain their connections. It keeps the highway system of the brain paved.
Okay.
In depression, likely due to chronic stress and high cortisol levels, the production of BDNF drops. Without that fertilizer, the neurons in the hippocampus, the part of the brain responsible for memory and emotion, begin to wither.
Wither. You mean that figuratively,
Yeah.
right?
No, I mean literally. Stop maintaining their infrastructure, the dendrites shrink, the connections break.
So when a patient says, I feel like I'm losing my mind, or I can't remember anything, or I can't concentrate, they aren't imagining it.
Not at all.
The hippocampus is physically struggling.
It can actually lose volume. If you MRI a chronically depressed brain that hasn't been treated, you often see a smaller hippocampus.
Wow.
The good news, and the sources are clear on this, is that successful treatment with antidepressants acts as neuroprotection. It can restore BDNF levels, essentially halting that atrophy and allowing the brain to rebuild.
That raises the stakes significantly. We aren't just treating a mood, we're preserving brain tissue. We are engaging in organ protection.
We are protecting the organ, exactly. It's no different than treating high blood pressure to protect the heart.
Before we move to the symptoms, I want to briefly touch on the neurotransmitter web. We tend to talk about these chemicals in silos. Serotonin does X, dopamine does Y, but they're tangled, aren't they?
Inextricably. You cannot pull one string without the whole web moving. There is a strong 5-HT-norepinephrine link. The serotonin and noradrenergic systems modulate each other. You rarely affect one without influencing the other.
And what about dopamine's role in this?
And then you have dopamine, specifically in the mesolimbic pathway.
The reward circuit.
Right. If that pathway goes dark, you get one of the hallmark symptoms of depression. It's not sadness, it's the total absence of feeling.
A void.
It's a void.
Which is the perfect segue to section 2, the clinical picture. Because I think media portrays depression as crying in a dark room, and sure, that happens, but the clinical reality is often much more numb.
It's called anhedonia. And for a diagnosis of MDD, you need one of the big two. The first is depressed mood, which in kids or teens often looks like irritability or anger, by the way.
Which is a huge red flag for parents. The grumpy, snappy teenager might actually be a depressed teenager.
Exactly. They don't have the vocabulary to say, I am in despair, so they act out. But the second of the big two is anhedonia. Diminished interest or pleasure in activities you used to love.
So if you love painting, and now you look at a canvas and it's just a blank wall.
It feels like looking at a blank wall. If you love football and watching the Super Bowl feels like watching paint dry, that's anhedonia.
So to get the official stamp of MDD, you need one of those big 2 plus 5 symptoms from the larger constellation list, present nearly every day for a 2-week period.
And this is critical. There must be no history of mania or hypomania.
Why is that rule so hard and fast? Why does one episode of high energy change the whole diagnosis?
Because if they have ever had a manic episode, high energy, sleeplessness, grandiosity, risky behavior, Then the diagnosis is bipolar disorder, not MDD.
And the treatment is completely different.
Radically different. If you give a bipolar patient a standard antidepressant without a mood stabilizer, you can throw gasoline on the fire. You can flip them from depression straight into a full-blown manic episode, which can be dangerous.
So ruling out bipolar is step one. Once we're in MDD territory, let's look at that constellation of symptoms. It's a mix of the physical and the mental.
It is. You have the biological rhythms going haywire, sleep, either insomnia, can't sleep no matter how tired you are, or hypersomnia, sleeping 18 hours a day and still waking up exhausted.
Right, and appetite.
Appetite, significant weight loss or weight gain. Some people starve, some people self-medicate with food.
Then you have the movement issues, which I find fascinating. Psychomotor agitation or retardation.
Retardation in the medical sense means slowing down. Patients describe feeling like they are moving through molasses or walking underwater.
Wow.
Their speech slows, their thinking slows. It takes 5 seconds to answer a simple question.
And agitation, what does that look like?
Agitation is the opposite. The inability to sit still. Pacing, hand-wringing, picking at skin. It's an internal restlessness that is agonizing. It's like having an itch inside your bones that you can't scratch.
Then comes the internal narrative. Fatigue, loss of energy, and feelings of worthlessness or inappropriate guilt.
That guilt is insidious. People feel guilty for being sick, or they fixate on a minor mistake from 10 years ago, like a comment they made at a party, and view it as proof that they are terrible human beings.
It's a distortion.
It's a cognitive distortion. The lens through which they see the world is warped.
And finally, the cognitive toll.
We mentioned this with the hippocampus, but clinically it presents as brain fog, diminished concentration, indecisiveness. Patients often think they're getting early onset dementia.
I can see why.
They read a paragraph 5 times and absorb nothing. It's not just an emotional disorder, it's an intellectual impairment during the episode.
And we can't ignore the physical toll. The source notes that 90% of outpatients present with anxiety, but many also present with physical pain.
Headache, back pain, GI issues. Serotonin and norepinephrine also regulate pain pathways in the spinal cord. If those levels are off, your pain threshold drops.
You literally hurt more.
You literally hurt more. Often a patient goes to their primary care doctor for back pain, and the root cause is actually untreated depression. The mind and body are not separate entities.
So we have a patient who is hurting, tired, can't think, and feels no pleasure. We've diagnosed the engine failure. Now section 3, the strategy. How do we fix it?
We have to be strategic. We don't just throw pills at the problem. The goalposts are clear. 1, remission. Not just feeling better, but the total absence of symptoms. We want you back to baseline.
Not just managing it, but eliminating it.
Eliminating it. 2, preventing relapse. And 3, returning to pre-morbid functioning, getting back to who you were before the crash.
But this is a marathon, not a sprint. The timeline of healing outlined in the research is distinct. And I think explaining this timeline manages a lot of expectations.
It requires patience. So much patience. You have the acute phase, 6 to 12 weeks. That's the battle for remission. That's finding the right drug at the right dose.
Okay.
If you win that battle, you enter the continuation phase, which is 4 to 9 months.
This is the danger zone, isn't it?
It is, because the patient feels good. They think, I'm cured. I don't need these pills anymore. I don't like the side effects.
I'm better.
Right. I'm better. If they start now, the depression almost always boomerangs back. You have to keep the scaffolding up while the cement dries. The brain needs that time to stabilize the receptor changes we talked about.
And then, after that
The
period,
maintenance phase, 12 to 36 months or longer. This is about preventing a totally new episode down the road.
and for some people, the recommendation is lifelong.
Yes. The data suggests that if you are under 40 and have had 2 episodes, or anyone of any age who has had 3 episodes, the risk of recurrence is so high that the safest path is indefinite maintenance.
It becomes a chronic condition management strategy, like hypertension or diabetes.
Exactly. You don't stop taking insulin because your blood sugar was good yesterday. You take it to keep it good today.
Now, before we open the medicine cabinet, we have to acknowledge non-pharmacologic options. For mild to moderate MDD, we aren't jumping straight to drugs.
No, absolutely not. Psychotherapy, CBT, interpersonal therapy, behavioral activation is first line. It works. For many people, it is as effective as medication. And for almost everyone, the combination of therapy plus drugs is better than either alone.
And for the severe treatment-resistant cases, we have the heavy hardware, ECT and RTMS.
Electroconvulsive therapy, ECT, gets a bad rap from movies like One Flew Over the Cuckoo's Nest.
Of course.
People picture convulsions and screaming, but medically, it is the gold standard for rapid response. If a patient is catatonic, refusing to eat, or acutely suicidal, ECT can turn them around in 10 to 14 days. It is safe, done under anesthesia or with muscle relaxants, and it is highly effective.
And RTMS.
RTMS stands for Repetitive Transcranial Magnetic Stimulation. It's the newer cousin. It uses magnetic fields to stimulate the nerve cells in the brain. No anesthesia required. You can drive yourself home after the appointment. It's another tool in the box when meds aren't doing the trick.
Okay, let's take a deep breath. We are entering section 4, the pharmacological arsenal. This is the jungle we talked about.
It really is.
We are going to break this down class by class, looking at the pros, the cons, and the weird quirks of each drug family.
We have to start with the rock stars, the SSRIs.
Selective serotonin reuptake inhibitors. These are the ones everyone knows. Prozac, Zoloft, Celexa. Why are they the first line? Why does every doctor start here?
2 words: safety and tolerability. In the old days, if you took a bottle of antidepressants to end your life, you likely would succeed.
Wow.
With SSRIs, it is very difficult to fatally overdose on the pills alone. That safety factor is huge when you are treating a population that might be suicidal.
Okay, that makes sense. So they work by blocking the reuptake pump, leaving more serotonin in the synapse. But they aren't interchangeable. They each have a personality. Let's talk about the grandfather. Fluoxetine, Prozac.
Fluoxetine is unique because of its incredible staying power. It has a massive half-life.
What does that mean for the patient, practically?
It means it stays in your system for 4 to 6 days with chronic dosing, and its active metabolite, norfluoxetine, lasts up to 16 days.
So if you forget a pill,
If you forget your pill on Tuesday, you won't feel withdrawal on Wednesday. It basically self-tapers. It leaves the body very slowly. But the flip side is, if you need to switch to a drug that interacts with it, like an MAOI, you need a 5-week washout period to make sure it's completely gone, or you risk a fatal reaction.
it's also known for being activating.
Yes, it can give you a jolt of energy. That's great for the patient who can't get out of bed, a lethargic depression. It might be bad for the patient who is climbing the walls with anxiety and insomnia. It feels like too much coffee.
Right. Then we have citalopram, Celexa.
A solid middle-of-the-road drug, but it has a specific warning. You typically don't go above 40 milligrams a day.
Because of the heart.
QT, interval prolongation. It can mess with the electrical recharging of the heart muscle. So for elderly patients or those with heart conditions, we have to be very careful with the dose.
And paroxetine, Paxil. What's its story?
I call this the sticky one. It has the shortest half-life of the bunch, meaning if you miss a dose, you feel it fast. The withdrawal or discontinuation syndrome can be nasty. Dizziness, nausea, brain zaps. It also has more anticholinergic side effects, dry mouth, sedation, constipation, but precisely because it is sedating, it can be very calming for anxious patients.
Now we have to talk about the side effect that nobody wants to talk about. The reason people stop taking these drugs.
Sexual dysfunction. It's the elephant in the room. Reduced libido, difficulty achieving orgasm, or total inability to achieve orgasm.
How common is it?
It affects a huge percentage of patients. Some studies say up to 60–70% depending on the drug. It is vastly underreported because people are embarrassed to tell their psychiatrist.
Of course.
But it is real, and it is a major barrier to compliance. People choose depression over the loss of their sex life.
Which brings us to the next class, the NDRI, specifically bupropion, Wellbutrin. This is the un-SSRI.
It is the outlier. It doesn't touch serotonin. It hits dopamine and norepinephrine. Because of that, no sexual side effects. In fact, for some people, it might even increase libido.
That sounds like a miracle drug. Why isn't everyone on it?
It has its own kryptonite, seizure risk. It lowers the seizure threshold in the brain. This is dose dependent, so we have a hard ceiling of 450 milligrams per day.
Okay.
And this is a board exam classic. It is strictly contraindicated in anyone with bulimia or anorexia.
Why eating disorders specifically?
Because the electrolyte imbalances from purging or starving already lower the seizure threshold. If you add bupropion, you are lighting a match in a gas station. The risk of seizure skyrockets.
On it. Next up, SNRIs, venlafaxine, Effexor, and duloxetine, Cymbalta.
These are the dual action agents. They inhibit the reuptake of both serotonin and norepinephrine. They are often the next step if an SSRI doesn't work.
Venlafaxine has a quirk related to dosing, right?
It does. It's dose dependent. At low doses, it's basically just an SSRI. It only grabs serotonin. You have to push the dose up to get that norepinephrine engagement.
But when you do,
You have to watch out for hypertension, The norepinephrine can clamp down on blood vessels and raise blood pressure, so you have to monitor BP.
And duloxetine.
It's more balanced. It hits both receptors evenly across the dosing range. And because it boosts norepinephrine, it is surprisingly good at treating the physical pain we talked about earlier: back pain, neuropathic pain, fibromyalgia.
So it treats the depression and the hurt.
Exactly.
Let's get into the mixed bag. Trazodone. I feel like I only see this prescribed for sleep these days.
That's its main use now. It's a very sedating antidepressant. It knocks you out, but it causes orthostatic hypertension. You get dizzy when you stand up. And it has a side effect that is rare but memorable.
Uh-oh.
Priapism.
This is the medical emergency type of erection.
A painful, prolonged erection completely unrelated to sexual interest. It occurs in about 1 in 6,000 men. It requires surgical intervention to fix. Patients need to know this before they take the first pill.
Absolutely. Then there's mirtazapine, Remeron.
This one is fascinating. It blocks alpha-2 receptors, which are the brakes on the neuron, cut the brake lines, and the brain releases more serotonin and norepinephrine.
But the side effects?
Its side effect profile is very specific: weight gain and significant sedation.
That sounds terrible. Here, take this. You'll get fat and sleep all day.
Not always. Imagine an elderly patient with severe depression. They are frail, they have lost 20 pounds because they have no appetite, and they have severe insomnia.
I see.
Mirtazapine is 2 birds with 1 stone. It helps them sleep, it makes them hungry, and it treats the mood. You fit the drug to the patient's profile.
Okay, let's go back in time. The old guard. The TCAs. Tricyclic antidepressants. Why don't we use these first anymore?
We call them dirty drugs. Not because they are impure, but because they are messy. They don't just hit the target, they hit everything. They block histamine receptors, sedation, weight gain, cholinergic receptors, dry mouth, blurred vision, constipation, and adrenergic receptors, dizziness.
So the side effect burden is heavy.
It is. But the real problem is the danger. TCAs are lethal in overdoses. They cause heart block, cardiac conduction delays. If a patient takes a whole bottle of Prozac, they will likely survive. If they take a bottle of amitriptyline or dicypramine, they will likely die.
That's a massive risk when you are treating a suicidal population.
Exactly. Dicypramine even has a warning for sudden cardiac death in kids with a family history of heart issues. We keep these drugs in reserve for when nothing else works.
And finally, the nuclear option, the MAOIs, monoamine oxidase inhibitors, phenelzine, trenylcypramine.
These are the big guns. They work by inhibiting the enzyme, MAO, that chews up neurotransmitters. They stop the breakdown so levels skyrocket.
And they work well.
They are incredibly effective, but they come with the cheese reaction.
This is legendary in medical folklore. Tell us why a depressed patient on MAOIs can't go to a wine and cheese party.
It comes down to a compound called tyramine. Tyramine is found in foods aged cheese, cured meats, sauerkraut, soy sauce, tap beer. Normally, the MAO enzyme in your gut breaks tyramine down before it enters your bloodstream.
But the drug has inhibited that enzyme.
Right. So the tyramine gets into the blood intact. It acts like a releasing agent, and it dumps massive amounts of norepinephrine into the system all at once.
And your blood pressure?
Skyrockets. It's a hypertensive crisis.
What does that look like?
Explosive headaches, stiff neck, nausea, risk of stroke or heart attack. It can be fatal.
So the dietary restrictions are life or death.
They are. And the drug interactions are just as scary. You cannot mix MAOIs with SSRIs or even some over-the-counter stuff like cough syrups containing dextromethorphan. It triggers serotonin syndrome or hypertensive crisis. You need a strict, disciplined patient for these drugs. You can't just casually take a cold medicine.
That leads us perfectly into Section 5, safety warnings. We've dropped the term serotonin syndrome a few times. What does that actually look like?
It's what happens when you have too much serotonin flooding the system.
Yeah.
It's a toxicity. It usually happens when you combine drugs. It presents as a triad of symptoms.
Okay.
1, mental status changes, confusion, agitation, delirium. 2, autonomic instability, fever, racing heart, sweating, blood pressure swings.
And 3, neuromuscular abnormalities.
This is the tell: clonus. Rhythmic muscle spasms, hyperreflexia. If you see a patient who is confused, sweating, and their foot is tapping rhythmically and uncontrollably when you push on it, that's a medical emergency.
Wow.
You stop the meds immediately and get them to the ER.
And we have to address the black box warning. It's on every antidepressant label. Increased risk of suicidality in children and young adults.
This is a paradox that scares every parent. How can an antidepressant cause suicide? The data is nuanced. Retrospective studies didn't find a significant increase in actual suicide deaths, but there was an uptick in suicidal thinking and behavior in patients under 25.
The theory behind this is chilling, but makes physiological sense. It's about energy versus mood.
Correct. As we discussed, norepinephrine affects energy, serotonin affects mood. Sometimes the drug fixes the energy problem before it fixes the mood problem.
So you get your energy back first.
Right. So you have a patient who was previously too lethargic to get out of bed, too depressed to even plan a suicide, who suddenly has the physical energy to plan and execute an attempt, but they still feel the internal despair.
That window, those first few weeks of feeling a bit better, is actually the most dangerous time.
It requires vigilant monitoring. Families need to know this. He seems more energetic isn't always a sign of total recovery. It can be a sign of risk.
Finally, Section 6, special populations. Because you can't just give everyone the same pill. Let's talk about the elderly.
The mantra is start low, go slow. You usually start at half the normal dose. Old kidneys and livers process drugs slower, and they are incredibly prone to orthostatic hypotension, that drop in blood pressure when standing.
Why is that a big deal?
Falls. If an 80-year-old falls and breaks a hip, the mortality rate is high. We want to avoid falls at all costs, so we usually stick to SSRIs and avoid the TCAs.
Kids and teens.
Very restrictive. Fluoxetine, Prozac, is the only drug FDA approved for depression in patients under 18. The safety data just isn't there for the others in the same way. We tread very carefully here.
And pregnancy. This feels like an impossible choice for a mother.
It's a risk-benefit analysis. There are risks to the baby with SSRIs, specifically PPHN, a serious lung condition, if taken late in pregnancy after the 20th week. There is also a risk of low birth weight.
But the alternative is untreated depression.
Which is also dangerous. Untreated depression leads to poor prenatal care, higher cortisol levels affecting the fetus, and maternal suicide risk. And here's the kicker. If a woman stops her meds during pregnancy, she is 5 times more likely to relapse.
5 times.
A healthy baby needs a healthy mother. Often, staying on the medication is the safer choice for the family unit.
Last question. What if the first drug doesn't work? We've tried Prozac, we waited 6 weeks.
Nothing. That is the reality for many. The STARD study, a massive real-world trial, showed us that the first drug fails a significant amount of the time. Remission rates on the first try are only about 30%.
That's discouraging.
But the study also showed us that we shouldn't give up.
What's the play?
If you switch to a different drug, say from an SSRI to an SNRI, about 1 in 4 people will achieve remission. If you augment, meaning you add a second drug like lithium or a tiny dose of thyroid hormone, T3, or an atypical antipsychotic, 1 in 3 will achieve remission.
So it's an algorithm. Maximize the dose. If that fails, augment. If that fails, switch.
It's trial and error, but it's educated trial and error. You keep trying until you find the combination that unlocks the lock.
We've covered a massive amount of ground today.
Yeah.
From the hippocampus shrinking to the cheese effect.
It highlights that MBD is not a weakness. It is a complex interplay of biology, environment, and genetics. It is a medical condition as real as diabetes.
And the final takeaway from our source material really stuck with me. It's a reframing of how we view dependence on medication.
Yes. There is so much stigma about being on meds forever. I don't want to use a crutch. I want to do it on my own.
Right.
But for many, these drugs aren't a cast that you wear until the bone heals. They are insulin.
It's a maintenance strategy for a physiological deficit.
Exactly. A diabetic isn't weak for needing insulin to regulate their blood sugar. A depressed patient isn't weak for needing an SSRI to regulate their serotonin and BDNF. It's about maintaining the machines so you can live your life.
We have effective tools. 65 to 70% of people get better with therapy and medication. But finding the key takes patience.
And it takes courage. It takes the courage to endure the side effects and the lag time while waiting for the dawn.
Thanks for taking the deep dive with us. Hopefully this helps you understand the jungle a little better.
Take care.
See you next time.